Hi guys, let's see about some physiology of congenital heart defects. There's a pre-tricuspid shunt, which is usually the atrioseptal shunt, which shunt or proximal to the level of atria. This shunt is predominantly determined by the pressure of the right ventricle. Usually at birth, the right ventricle is stiff, so the shunt across the ASD is very small. Over the years, as the child grows, the right ventricle enlarges and the pulmonary vessels also increase in its capacitance to accommodate the excess flow. So, patients with ASD rarely develop features of increased pulmonary blood flow. Now, coming to post-tricuspid shunt, which is usually the ventricular septal defect. Here, there is direct pressure transmission from the systemic to the pulmonary circuit. So, the shunted blood flows directly to the pulmonary circulation, and it also reaches the left heart and increasing the diastolic volume overload of the left heart. So there is more flow in the pulmonary pulmonary vasculature, causing hyperkinetic pulmonary hypertension. So this is due to the increased blood flow in the pulmonary blood vessel, and it regresses on treating the shunt. Consequences. So the consequence here is based on the size of the defect, and large VSD can therefore begin to have symptoms early in the infancy. So as we know, the pulmonary vascular resistance is more at birth. It gradually reduces over a few weeks in the infancy. So the patient, after fall of vascular resistance, the patient can develop symptoms of volume overload and also increased pulmonary blood flow. Now coming to VSD, ventricular septal defect pulmonary stenosis physiology, which is more commonly seen in the tetralogy of fallout. Here there is communication at the ventricle level with an obstruction to the pulmonary flow. So here what we are saying is severity of the pulmonary stenosis is directly proportional to the cyanosis. So logically thinking, pulmonary stenosis, if there is more pulmonary stenosis, the blood flowing to the pulmonary artery is less, so the oxygenation is less, so the cyanosis is more. So here this is with the exact thing in cyanotic spell. When there is more severity of the pulmonary stenosis, the intensity and duration of the ejection systolic murmur across the pulmonary valve decreases and there is more cyanosis. Next, coming to single ventricular physiology. This occurs in conditions like truncus arteriosus, a severe hypoplasia of one ventricle with this complete mixing of pulmonary and systemic venous returns. Here the effect is based on the presence or absence of pulmonary stenosis. If there is no pulmonary stenosis, there will be increased pulmonary blood flow. So cyanosis is minimal here, but permanent increase of vascular resistance, pulmonary vascular resistance is there. In the presence of pulmonary stenosis, it is more likely to VSD